Hello, I'm Sean Kennedy. I'm the editor-in-chief of the American Journal of Nursing. You're listening to a podcast in our Behind the Article series, which are interviews with authors of AJN articles. You can find all of our podcasts on our website, ajnonline.com, under the Multimedia tab, as well as on iTunes, Spotify, and Google. AJN's content, including the article we refer to in this podcast, is accessible in print, online on our website, ajnonline.com, or you can also find the articles on the Ovid database. You can also find AJN content on social media, including Facebook, Twitter, LinkedIn, Instagram, and our blog, AJN Off the Charts. Today, I'm very pleased to be speaking with physician Cart Sharma and nurse practitioner Faith Newton from the Departments of Neurology and Neurosurgery at the University of Texas Southwest Medical Center in Dallas. Along with nurse practitioner colleague Essie Matthews, they are the authors of a CE feature article in the October issue of AJN. Their article, Hypertensive Emergencies, a Review, provides a comprehensive look at the spectrum of uncontrolled hypertension. It also discusses the importance of distinguishing hypertensive emergencies from hypertensive urgencies, and we'll get into that in the podcast. It also describes the pathophysiology, clinical manifestations, and management of hypertensive emergencies. So it's a really nice comprehensive review. Cart and Faith, thank you for taking the time today to chat a bit about this very important topic and your article. I do apologize for my raspy voice. I'm recovering from a summer cold. So welcome.
Thank you so much for having us today.
Pleased to be with you.
Before we get to the article, could you talk a little bit about your work at UT Southwest? How do you work together, and what do you primarily do clinically?
Sure.
So, Dr.
I am. Go ahead, Faith.
So, Dr. Sharma and I work together in the neurotrauma ICU, seeing patients and managing patients who present with critical care needs due to neurological issues.
Okay, and Cart?
That's correct. Just a little bit about my background. I trained in, did an internship in internal medicine, followed by a residency in neurology, and then a fellowship in neurocritical care. And as Faith mentioned, I attend on the neurocritical care units at UT Southwestern, and seeing patients with neurologic critical illness, which also include, and part of the motivation for this review, patients with the neurological hypertensive emergencies or neurological complications of treating hypertensive emergencies, both of which we discuss in the article.
Mm-hmm. How big is the neuro unit there?
The main unit at Clements University Hospital is about 24 beds. And we are quite a busy unit, almost at capacity most of the time. And our division also staffs additional neurocritical care units at the county hospital, which is Parkland Hospital. That's about a 10-bed facility, and the Presbyterian Dallas Hospital, which is another 10-bed facility for the neuro ICU.
Oh, it's a very busy service.
Certainly.
So in the article, you make it clear regarding the difference between a hypertensive urgency situation versus an emergency. Can you talk a bit about why that's such an important distinction?
That's right. In the article, when we proposed the definition of hypertensive emergency, we have a reported and accepted threshold of a systolic blood pressure of above 180 and or a diastolic blood pressure of above 120 millimeters of mercury as a definition. But what's critical is not necessarily the number itself, but perhaps the presence of end organ damage. Mm-hmm. And by end organs, this could be brain, kidneys, heart, eyes, and that's primarily what distinguishes hypertensive emergencies from urgencies, because somehow with the same degree of blood pressure elevation, In the setting of an emergency, there seems to be some kind of a self-sustaining process where the elevation in blood pressure, once it starts causing end organ damage, leads to an exponential increase in the damage via mechanisms that we again discussed in the article. And that's critical to identify because the management of that is quite emergent, as the name suggests. This would require hospitalization, preferably to an intensive care unit. The interventions required are time sensitive, and the goals of treatment may need to be achieved rapidly, as opposed to a hypertensive urgency, where you may have a similar blood pressure number, but in the absence of ongoing or impending end organ damage, the management of that can be somewhat less expeditious. And perhaps is preferably less expeditious because you want to avoid over-aggressive treatment, which has its own complications, and so that can be managed perhaps on an outpatient basis by initiating oral medications or changing or increasing existing medications, and so that this distinction is quite important.
So you touched upon the time frame. As a former ER nurse myself, the old adage "time is brain" has always stuck with me, and time was always the enemy. And I remember when we used to have someone coming in with hypertensive or what we used to call hypertensive crisis, and certainly complaining of any of the severe symptoms, headache, etc. Yet some of that would be classified as urgency. So Faith, when a patient comes in with severe hypertension, elevated blood pressure, in terms of the numbers that Cart was just saying, over 180, over say 110, what would you say, what are the first steps that a nurse, an ER nurse, or if it's a nurse in ambulatory care clinic, wherever, should think about in terms of assessing, what's the first thing they should be really looking at to determine, is this an urgency situation versus an emergency?
The difference between the two, you're looking for evidence of end target organ damage. Probably the most common signs that we see would be changes in urine output, indicating that the perfusion to the kidneys is altered, and neurological deficits for patients that may present looking like a stroke and could in fact be a stroke. Weakness on one side, visual disturbances. It could also just be that they're altered and they're less responsive than they normally would be. Changes in vital signs. Those are probably the most common objective signs that any nurse can start evaluating to know something is wrong with this patient, and this may be an indication of hypertensive emergency.
And then what's the next step after that? So somebody comes in and it used to be, I know there was a CAT scans or MRIs. I mean, what's the next step after you really looking at the determination if there's no real obvious signs of end organ damage at that point?
Dr. Sharma, do you want to take that one?
Oh, sure. And I just wanted to add, in addition to some of the common signs and symptoms of a neurological deterioration that you could elicit in an ambulatory setting for the neurological assessment, there might also be commonly cardiovascular manifestations like chest pain, shortness of breath from a symptom standpoint. And then in terms of signs that could be elicited, you could have, especially in the setting of something like an aortic dissection, you could have a difference in the pulses in each arm, or a difference in the blood pressure in each arm. And so the assessment
evidence of poor perfusion.
Correct. Perhaps in an ambulatory setting would involve, what essentially would amount to a clinical assessment where you elicit symptoms and then look for signs. Which may involve just taking vital signs, or it may involve ordering lab tests where you may order a urinalysis to look for evidence of kidney damage, or you may order a complete blood count to look for evidence of hemolysis, which can occur with high blood pressures. Or perhaps it may be a specialized examination if there's visual symptoms where you might refer somebody to have a fundus examination where they look at the back of the eye and to look for retinopathy. And so once that determination has been made of a lack of end organ damage, then you can be more comfortable assuming that what we're dealing with is a hypertensive urgency. And in that circumstance, in an ambulatory setting, you could assess what the patient's existing medications are. Are there any underlying conditions responsible for the hypertension? For example, some patients have pre-existing renal disease, which is causing hypertension. And so management would be kind of akin to a primary care setting where you would titrate therapy, increase, add, or change medicines with reasonably close follow-up, where you want to hear back from the patient once they've left the clinic or the ambulatory setting with whether the medicines worked and if there are some adjustments required, without necessarily having a repeat visit, but perhaps something you could do remotely or over the phone. And certainly in this day and age is quite convenient.
Right. Would you ever, start treatment in the ER just to make sure that perhaps where you're seeing the patient at maybe they may not be at the end point of where they were going with their hypertension crisis, so that perhaps you got them early and they were, instead of sending them home where they're to take medication PO, that perhaps they're only halfway to where they're on their way. If I don't know if I'm explaining this right, but say they're
certainly,
yeah.
I actually understand the gist of your question. Most certainly, and part of it might be contingent on why they're in the ER versus an ambulatory setting. And so if there were symptoms that promoted the visit to the emergency room, like it might be a severe headache, or it might be chest pain or palpitations, those certainly are within the realm of a possible hypertensive emergency. And so could it be that the patient you're evaluating is going to have impending end organ damage, and it perhaps hasn't happened yet?
Right.
So most certainly you could attempt to start initial treatment, either oral or IV, in the emergency room, to take that as an opportunity to prevent a hypertensive emergency. That certainly could be done. But a lot of the time, these patients will be referred to the emergency room simply because the blood pressure was found to be high somewhere.
Right.
In an ambulatory setting, in a clinic. And so perhaps our kind of motivation to differentiate the two is to prevent that kind of an unnecessary emergency room visit, where a simple outpatient assessment and testing could safely rule out end organ damage. And once that's determined not to be the case, then oral therapy could be initiated. And then that could certainly be done in an emergency room.
Right.
If you see somebody who came in, they were sent by their primary care doctor because the blood pressure was high, the emergency room assessment would include an EKG, some labs, checking vital signs, and looking at the eyes. And if there was no end organ damage, then they could prescribe oral medicines as a kind of a bridge to resuming care outpatient.
Yeah. So
we see patients.
Go ahead.
We see patients frequently who are presenting with a neurological problem that is secondary to hypertensive emergency. But I know the ER also frequently sees people that we get in who maybe have just taken their blood pressure at the pharmacy and found that their systolic was over 200, and they were told you should probably go to the ER. So they're coming in with alarmingly high blood pressures, but
nothing else,
no signs or symptoms of hypertensive emergency.
So the number alone is what some people will spark people to come in, or someone to send them in because they're looking at the number, even though the person may not have that crushing headache or shortness of breath or anything else. And once they have those type of other symptoms, that's when they really need to be seen in the ER.
Correct.
Okay. One thing I was struck was in talking about the balance between lowering blood pressure, but the caution that you must use to make sure you're not lowering it too quickly. Cart, could you talk a little bit about the recommendations on that aspect of treatment?
Sure. unfortunately, I get to see in the neuro ICU perhaps the worst manifestations of an unsafe reduction in blood pressure. And primarily the risk is in our attempts to reduce the number as quickly as possible. These organs that were seeing some high blood pressure, and this could be the brain, the heart, the kidneys, we're seeing some high blood pressure for some length of time. When you have a reduction in blood pressure that's sudden, there is an inability of the blood vessels or the vasculature in those organs to respond to maintain perfusion. And what I'm referring to is autoregulation. What that is within the organs, there is a, especially the brain, there is an ability to maintain a steady blood flow despite changes in systemic blood pressure. And so the brain, for example, when you have a higher blood pressure within a physiological range, will have vasoconstriction and will limit blood flow more than necessary to the brain. And on the flip side, when you have a drop in blood pressure, you will have a vasodilation in the brain to maintain the same blood flow. But in a patient who's hypertensive or in the throes of a hypertensive emergency, that mechanism may be impaired. So when you drop the blood pressure, you do not get that compensation of increase in blood flow. So you actually do decrease the blood flow to the organ. And for us in the neuro ICU, it'll manifest as an acute stroke because of loss of blood flow to a certain region of the brain. In the heart, it could manifest as an MI, and that's because flow to the coronary arteries is contingent on diastolic blood pressure. So dropping it too much can cause damage. And then in the kidneys, that could manifest as a renal injury, which has been actually seen in some of the trials that were conducted in intracerebral hemorrhage and blood pressure lowering to an aggressive degree.
So what's the target when someone comes in with a high blood pressure? I mean, is there a percentage that you go for in terms of, only lowering it by so many millimeters, or is it you just go by the diastolic number versus the systolic number? How do you judge how quickly or how successful you are in terms of managing that?
We've tried to address that. The answer to that question is somewhat nuanced, and what we've tried to bring out in various parts of the article is that the goal isn't necessarily a percentage or a number. The goal is a reduction while avoiding end organ damage. Now, that being said, that doesn't really help kind of the practical aspects of what to do. And so, you guys, as a rule of thumb, a general recommendation would be reducing blood pressure in the first hour by no more than 25% of the initial value. And then over the next 2 to 6 hours, it could perhaps be reduced further to a goal of, say, 160 over 110. And then over the ensuing several-day period, 1 to several-day period, could be brought back to a normal range. No, but there's several riders to that general recommendation, and which we have tried to break down in the review again, because there are several exceptions. You may want to have a very rapid reduction in blood pressure if you have a hypertensive emergency called an aortic dissection, which is a tear in the aorta, and an immediate reduction in blood pressure and heart rate is paramount to prevent that from causing death.
Right.
Or on the flip side, you may want to not reduce the blood pressure, even at the rate that I just described. And that may happen in the setting of an acute ischemic stroke, where you have a blockage of an artery to the brain. And so there may actually be tissue that is not ischemic yet, that is still getting some reduced blood flow because the blood pressure is high. And so by dropping the blood pressure, you may compromise that remaining tissue. And there are several other exceptions to this rule. For example, a pregnancy-induced hypertension, for example, just blood pressures over 160 over 110 might result in a hypertensive emergency called preeclampsia or eclampsia. And so in those cases, you want a more expeditious reduction to a goal that's generally lower than what I described.
Right.
And so it bears in mind characterizing what hypertensive emergency is being treated. beyond
Right.
just the high blood pressure. What end
And
organ is the one being damaged, and what end organs are the one we are trying to prevent damage to during the blood pressure reduction.
right, it really is such a delicate balance, and in the context of what else is happening physiologically. So that's so the assessment, and I guess Faith, with the work that you do in the ICUs, I'm assuming a lot of it is educating the nurses in terms of what they should be watching for, and in terms of parameters as this process is happening.
Oftentimes for us, the most important part of our exam is really the neurological exam. And so teaching everyone to pick up on changes in the exam is a big part of making sure that we've not been too aggressive in the goal setting for a patient. I can tell you that when I was a bedside nurse, I had a patient who had intracranial hemorrhage and was very sensitive to blood pressure reduction. And when he was admitted was, normal neurological exam, had a headache, but was able to respond appropriately, move everything. And then with reduction in his blood pressure, and really this started about the time his systolic was 160, became obtunded.
Mm-hmm.
And although we would have liked to have targeted a lower blood pressure goal for him, we found that we really had to stay about 180 for him to have good cerebral perfusion.
Mm-hmm. And I don't think a lot of what med surg nurses might realize the nuances that you both just presented in terms of this, or certainly not new nurses who are new to critical care may not realize this delicate balance. So I'm really happy that was really brought out well in the article. And you also have there's a great table that you did of medications, and that'll be very helpful. I've been told by several nurses that we try and do visuals like that, tables, pull out some things, whether it's assessment parameters or medications, and I've been told by several nurses that they have that page torn out and it's hanging on their bulletin board, those types of things. So
that's wonderful to hear.
Yeah, those tables are really useful, and people learn different ways. So some people have it's in the text, but then to be able to have one table or a box that clearly says here's the everything that all the medications are right here, and their uses and etc. side effects and of that nature. So I think those things are really important, and you've done them very well in the article. So thank you very much for that. I think it'll be a very useful article, and it is a CE feature, which means anyone can read it. It's a CE feature for at least 2 years, and then they'll review it to see how current it is, and sometimes extend it. But for 2 years, it'll be freely available to anyone who wants to read it. So we'll be tweeting and putting it on Facebook, and we'll probably do a blog post just to make sure it gets out there. So thank you again for a great article. And I know my good friend Daiwai has reached out to you to get this done, and he's reached out to some other people. So I think UT Southwest is going to be well represented in AJN over the next couple of issues.
It's my pleasure.
Thank you very much.
Thank you.
Thanks for having us.